Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology, and we are now up to week 7. Moving right through our book, we are starting on chapter 22 this week. We are covering chapters 22, 23, 24. I know it doesn't seem like much, but the section on narcotics and general, local, and regional anesthetics has quite a bit of information in it. So I'm kind of glad that we're just focusing on a small type group of information this week. If you look at your syllabus, you will see that we are still focused on unit objectives 9.3.1, 9.3.2, 9.4.1, and 9.4.2. Okay, if you want to follow along in your book, which is not necessarily necessary, but if it's something you want to do, you're more than welcome to. And we will be on page 117 to begin here. All right, so let's keep going. As I said, this week we're going to talk about narcotics, also known as opiates or opioids, general anesthetics, and regional anesthetics are included under local. And we'll talk about what those are. But before we start into our specific drugs for the week, we want to talk about tolerance and dependence. And remember, we talked about those last week in week 6, but we're back to talk about them in week 7 because so many of the drugs that we're going to talk about under opiates, pretty much all of them, have issues with tolerance and dependence. So let's review. Tolerance is a physiological state. It's a physical state, not psychological, only physical. So make sure you notice that first. Tolerance is a physiological or physical state characterized by a reduced drug effect with repeated use of the drug. So the more you use the drug over time, the less its effect is. And higher doses of the drug are needed to produce the same effect. So not only do you see that over time the drug effect is reduced, but you have to have higher doses to get that same effect. It means it's reduced effectiveness of one effect. Tolerance can be due to increased elimination of the drug or reduced effectiveness of the drug receptor interaction. Those are thought to be the two ways that tolerance occurs. Is that either our bodies get used to it and we increase our elimination of the drug through the liver and kidneys, or it's one of those situations where as you've been on the drug over time, the drug receptor interaction is not as strong as it was when the drug was first introduced. And so you have to have higher and higher doses of the drug to still get that same effect with the drug receptor interaction. Tolerance develops with time in most patients that are on opiates or opioids or narcotics. That is one of the dangerous parts of narcotics, is that in order to get the same pain relief or the same sense of whatever that drug provides, whether it's sedation or whether that's relaxation, over time, the dosage has to increase in order for that effect to continue where it was. And unlike NSAIDs, and it'll be a couple of weeks before we get into those, but that's non-steroidal anti-inflammatory drugs. NSAIDs are a Tylenol or acetaminophen or an ibuprofen, Advil, Motrin, Aleve, that type of thing. But unlike that, there's no maximum dosage for opioids. Obviously, the more you take of opioids, the closer you can possibly get to respiratory depression, coma, and death. But you can increase the doses to get to that useful effect. Now, dependence is characterized by signs and symptoms of physical and or psychological withdrawal when drug levels fall. So when we're talking about dependence, we're talking about physical and or psychological. Typically, when you're talking about opiates, you're talking both physical and psychological. And then notice the key word here is withdrawal when drug levels fall. You have these signs and symptoms that occur when the drug levels fall. So tolerance is different than dependence. Tolerance is physiological only. Dependence is physical or psychological and has to do with withdrawal. Tolerance simply has to do with over time needing more and more of the drug. Dependence means that when the drug is removed or when the drug level decreases in the body, you're going to get signs and symptoms of physical and or psychological withdrawal. So let's look at fentanyl. Fentanyl is a very, I don't want to say popular, but well-known is probably a better word, well-known opiate or opioid. When someone has fentanyl withdrawal, they have intense cravings, anxiety, sweating, insomnia, muscle aches. They can have relapsed dreams, inability to experience pleasure, a pink cloud syndrome of ignoring reality, and they can have negative feelings. So they have some physical symptoms. They also have some psychological symptoms when they withdraw. The timeline for withdrawal starts within 2 to 4 hours. If they're on a fentanyl patch, it can be 24 to 36 hours. Their symptoms peak in 2 to 4 days, and their symptoms taper off and end in 7 to 10 days. Why would this be? Because if you think about the half-life, remember we had this talk weeks and weeks ago about half-lives and about how much of the drug you had to take till you got to the efficacy, the amount that is needed for the drug to be working at an optimal level. When that time frame is long, such as in days, the withdrawal timeline is long. When it's short, like with fentanyl, that meaning you take it and pretty soon after you take it, you start feeling the relief of pain and all the other lovely things that go along with fentanyl, then their withdrawal is going to be shorter too. It has to do with that half-life and when that drug level starts dropping in the human body. Factors that influence withdrawal include length of use, intensity of use, physical and mental health, and medical assistance. If you're doing a withdrawal, a medical withdrawal, say in an acute care detox unit, you can influence that withdrawal much more significantly than someone who is trying to withdraw on their own at home without any medical assistance. What are narcotics? That's probably a really good place for us to start with. Also known as opioids, the term narcotic comes from the Greek word for stupor and originally referred to a variety of substances that dull the senses and relieve pain. Today, narcotic refers to opium, opium derivatives, and their semi-synthetic substitutes. So we call those opioids. It can include everything from heroin all the way up through OxyContin, Vicodin, codeine, morphine, methadone, and fentanyl. If you've ever had a really bad cough and you've had maybe been given Tylenol with codeine, or you've been given a cough medicine that has a codeine component in it, you've had an opioid, you've had a narcotic. Most of these are natural. If they're a natural opioid, they've come from some variation of poppy. Synthetic opioids are made entirely in the lab. Meperidine, fentanyl, and methadone are examples of those. Semi-synthetic opioids are synthesized from natural occurring opium products such as morphine and codeine. These include heroin, oxycodone, hydrocodone, hydromorphone. Narcotics opioids produce a general sense of well-being. They reduce tension, anxiety, and aggression. Those effects can be helpful, but they can also contribute to the drugs being abused. And they do come with a variety of side effects. Some of those can be wanted, some of those cannot be wanted. They include drowsiness, inability to concentrate, apathy. Um, so there can be some unwanted side effects there as well. There are reasons why doctors prescribe opioids. It can be to treat pain, suppress cough, cure diarrhea, and to put people to sleep, help them if they're struggling with sleep. The effects depend heavily on the dose, how it's taken, and previous exposure to the drug. How can you tell someone is on an opioid or narcotic? Typically, they have constricted pupils. They may have some flushing of the face and neck. They may complain of constipation. May have some nausea, vomiting. They may show signs of slowed breathing or slowed physical activity. May seem like they're moving in slow motion, or they may feel they're moving in slow motion. As the doses increase, both pain relief and the harmful effects become more pronounced. Some of these preparations are so potent that a single dose can be lethal to an inexperienced user. Couple of things here. Because opioids do have that ability that not only do they take care of pain and they help with sleep, but they have a general sense of well-being by reducing tension, anxiety. That tends to make them very addictive. I know personally from taking an opioid for a very short period of time, I would say not even a week, I experienced that sense of well-being, of reduced tension and anxiety, and it is lovely, very lovely. I'm thankful that I only had to do it for a week and then that I'll never do it again, because it is very tempting to continue to have that relieved pain and not have to deal with it with other ways, and with those things. I'm also going to really quick share a true story of a lady that was a friend of mine for a brief period of time, who had some neck injuries and had some surgery, and through all of that process had been put on opioids to treat her pain, and became addicted. And when I knew her, she was trying her best to manage her addiction, and she was really struggling with it. She went through inpatient detoxification a couple of times, and in the end, she could not break the addiction. She kept going back to it, and as a result, she lost her family, her husband and 2 kids, and her life changed significantly in a very negative way. So, when you're talking about these drugs and when you're talking about these patients, you have to be super sensitive, as you would with any medical condition or any psychological condition. No one really sets out to become addicted to opioids. It's very easy to happen, and it's very hard to get off. And the effect that it can have not only on the patient but on their family is very challenging. And oftentimes, these patients, as much help as they need, their family also needs assistance to move through how to handle this process. Why is it important that we know about opioids? They are heavily prescribed. And as you can see here, the CDC has been tracking death rates due to overdose by opioid. And if you just look at the top line, which is the green line, the opioid overdose rate has just gone up tremendously. If you look at 1999, it was only 3 deaths per 100,000. We're now, as of 2017, 2018, in the 14 to 15 deaths per 100,000. Underneath that green line, you can take a look. There's a purple line that reflects commonly prescribed opioids. The orange line beneath that is heroin. The black line is synthetic opioids. And these can be from the street. Um, they can also be somewhat prescribed, but those are the synthetic ones. So let's break it down and go into some more detail. Narcotics act on specific receptors in the central nervous system to reduce the perception of pain. And I think this is a really important statement here. They reduce the perception of pain, not the pain itself. The patient still has pain, but the perception of it is what is reduced. So make sure you understand when you're talking about opioids, opiates, narcotics, they do not eliminate the pain. But the patient is no longer bothered by the pain because their perception of pain is reduced when you get these receptors blocked in the CNS. Your book organizes narcotics by their action, but if you look at how the world around us organizes narcotics, it's typically by how they're made. Are they synthetic, semi-synthetic, or are they natural? I'm not going to get into that delineation. I just think that we need to know that there are different ways that they are made. All opiates are agonists. Okay, all opiates are agonists. That means they act on those specific receptors to reduce that perception of pain. Now, having said that all opiates are agonists, we're also going to talk about two right now that are not agonists. They're actually antagonists, and they are really not opioids, but they impact opioids, and so they're covered in our chapter. The first one is naloxone, also known as Narcan. This is an antagonist that stops and reverses all opioids from working immediately. It can be obtained without a prescription. In fact, the government, both federal and state governments, are working together to get Narcan to individuals in the community without a prescription so that you can have it on hand. If you have a family member who's on an opioid and you're concerned that maybe someday they may accidentally overdose or they may accidentally get confused about when they took their last dose and take the next one too soon, you can get Narcan and have it on hand to be able to administer it to the person that you're with that you're concerned about. A lot of first responders have Narcan these days and are able to give it when they're called, whether that be police or EMTs, that type of thing. It has been tracked for a number of years, Narcan use in the ED of hospitals, in the OR of hospitals, for instance, when anesthetics need to be immediately reversed for whatever reason, and then anywhere else within a hospital setting. So anyway, you need to know naloxone is the generic, Narcan is the brand name. It's an antagonist that stops and reverses all opioids from working immediately, and it can be obtained without a prescription. It's not an opioid, but it counteracts an opioid, or all opioids, I should say. Naltrexone is an antagonist that blocks the euphoric and sedative effects of opioids and is often used to help reduce and suppress opioid cravings. So that's the second antagonist you need to know. Again, naloxone and naltrexone are not opioids. They're both antagonists. But naloxone, or Narcan, stops and reverses all opioids from working immediately. Naltrexone blocks the euphoric and sedative effects and can reduce and suppress opioid cravings. Naloxone or Narcan can be obtained without a prescription. Naltrexone does require a prescription. And again, I said all opiates are agonists. There is one, pentazocine, or Talwin is the brand name. It's both an agonist and antagonist used for moderate to severe pain. It's the only one that's not a pure agonist. All other opioids are pure agonists. Pentazocine or Talwin is one that has a bit of an antagonist aspect to it. So hopefully that all of this makes sense. All right, brand names, generic names, and street names. I didn't include the street names, but here are some brand names and generic names. I will give you a list of the ones that you need to be familiar with in a hospital or physician office setting. But this is sort of more the overall exhaustive list. These are combination opioid prescriptions. You can see how many of these contain acetaminophen, ibuprofen, that type of thing. All right, so what drug names do you need to know? And again, the generic name is given first. The brand name is what's in parentheses. So codeine is Tylenol number 3 or number 4. Fentanyl, you may hear of Duragesic, they adhere to the skin. I keep wanting to say pads, but that's not quite the right word. But they adhere to the skin and they allow the drug to seep through into the skin. Duragesic patches. And so that's a type of fentanyl. Hydrocodone is in Lorcet, Lortab, Tusionex, and Vicodin. Hydromorphone is in Dilaudid. Meperidine is Demerol. Methadone is just methadone. Morphine, you may hear of that as MS-Contin. Morphine is most often used with patients who are either in the dying process and or have cancer pain or pain that's related to some type of cancer. Oxycodone has brand names of OxyContin, Percocet, and Percodan. Oxymorphone is known as Opana. So when you're reviewing medical records, whether you're talking about physician office or the ED or the hospital, whatever setting you're looking at, even long-term care, you may see some of these names in there. And so it's important that you know, recognize them as an opioid. Okay, so what do these agonist opiates cause? What are some signs of use? We talked about this a little bit earlier. First of all, it's pain relief or analgesia. You may see respiratory depression. You may see spasms of smooth muscle of the GI, GU, or biliary tracts. And those spasms, it makes sense then that it would cause constipation because it's taking longer for things to move through the GI tract. And so you'd also see urinary retention with the genitourinary tract, and then you have biliary tract. Pinpoint pupils is a very common one. If you're looking at someone and they have pinpoint pupils, odds are they're on some type of opioid. Opioid actions can be therapeutic, even the side effects. Sometimes, for instance, a side effect of narcotics is constipation. If you have a patient with severe diarrhea and all other medications you have tried for that severe diarrhea are not working, a narcotic will definitely help that diarrhea to stop. It will balance it out. Constipation happens to be one effect that no one on an opioid develops a tolerance to. These opioids can also cause drowsiness, sedation, cough suppression, and urinary retention. So sometimes if they need those side effects, that's another reason why these narcotics may be prescribed. What are some signs of opioid withdrawal? It can include nausea and vomiting, diarrhea. because that's the opposite of constipation. Insomnia, anxiety, increased body temperature, racing heart, muscle and bone pain, sweating, chills, high blood pressure. And we talked a little bit about how long opioid withdrawal lasts, and it really depends on the drug. It depends on how long someone's been on it. It depends on their health. But what it says here is that heroin and short-acting opioid withdrawal symptoms can typically be seen within the first 8 to 12 hours after last used, peaks within 1 to 3 days, and continuation of up to 7 days. That's with heroin and short-acting. When you have longer-acting ones, it'll take longer. So, for instance, if you're talking about methadone, extended or controlled release formulations of morphine, oxycodone, hydrocodone, and fentanyl, they may not see their first withdrawal symptoms until up to 36 hours after last use, and the continuation of those symptoms up to 14 days or more. So that's why it really depends on what opioid you're talking about and whether it's short-acting or long-acting. And then again, the dosage, how much have they been on, how long have they been on it, all those types of things. So quick quiz questions, and just a reminder, I am pulling for your quizzes off these quick quiz questions. So if you can answer these quick quiz questions, you should be able to ace your weekly quizzes. What do narcotics or opioids do? Can they eliminate pain? What are the two non-opioid antagonists that we studied this week? Which one stops or reverses all opioids from working immediately? And which one blocks the euphoric and sedative effects of opioids and is often used to reduce or suppress opioid cravings during the withdrawal process? True or false? All opioids are agonists. Give me at least 3 generic names of opioids and at least 5 brand names of opioids. Make sure you know those, or can at least recognize them. Even if you can't spell them from scratch, can you recognize those? True or false? Opioid actions can be therapeutic, even the side effects. Name at least 3 signs of opioid use. Name at least 3 signs of opioid withdrawal. Name one factor, and there are several, that can impact how long opioid withdrawal can last. I know you can do this. All right, so moving on to anesthesia. The first section that we're going to talk about is general anesthesia. And this is on page 122 in your book. General anesthesia is most often used for major operations, such as hip and knee replacements, heart surgeries, I would say lung surgeries, where you're impacting the patient's breathing. Anything that's going to cause significant blood loss or has the potential to cause significant blood loss. So, you think about spine procedures, you think about neurological procedures that involve the brain, a lot of surgical procedures that are used to treat cancer, where you're needing to really control the patient's pain and their consciousness. General anesthesia makes the patient completely unconscious. So how does general anesthesia work? It is through inhalation or through IV injection. Those are the 2 ways that general anesthesia is induced into the body or administered. Obviously, during surgery or procedure, your heart rate, blood pressure, breathing, other vital signs are all being monitored to make sure that you are unconscious and free of pain. After the surgery's done, the medication, the anesthesia is reversed, and you'll return to consciousness. Some patients feel fine when they wake up. Others experience symptoms such as nausea, vomiting, or chills. You've been intubated with general surgery to keep your breathing functional to keep your airway open, to prevent choking and things like that. So your throat may sometimes be a little bit sore from the breathing tube. Um, Obviously, eventually the pain medicine wears off, so you can have some discomfort from the actual surgical procedure itself. All right, so general anesthetics. This is a drug-induced absence of perception of all sensations. Make sure you understand it. It's a drug-induced absence of perception of all sensations. You are unconscious, unable to sense any pain. The depth of anesthesia is achieved through a wide variety of drugs. Oftentimes, 2 or more drugs are used with general anesthetics. They're administered by inhalation or IV injection. That's so they can control the dose and the time, how long it lasts, that type of thing. Most drug mechanisms for general anesthetics are unknown, how they actually work on a very low cellular level. General anesthesia is used for surgical procedures that take a long time, affect a patient's breathing, may lead to significant blood loss, or require exposure to a cold environment. There are 2 types of general anesthetics. There are those that are inhaled and those that are IV. And so let's break those down. This graphic just shows you that there are inhaled general anesthetics. They usually fall into nitrous oxide gas or other volatile liquids. Halothanes. If it's an IV injection, it can be, review from last week, barbiturates or benzodiazepines. Remember that? We did that last week. There are also dissociative types of anesthesia called ketamine, opioids like fentanyl, and then some miscellaneous ones that include etomidate and propofol. And you may remember hearing about propofol, if that one's familiar to you, through Michael Jackson's, the trial of the doctor that treated Michael Jackson and gave him propofol outside of an OR, and it caused Michael Jackson's death. So that may be where that term might be familiar. This slide, I wanted you just to simply see the stages of anesthesia, because once you see the stages of anesthesia, then it makes sense how some patients can have issues when they're either going under anesthesia or coming out. And it's more often the issues are coming out of anesthesia rather than going in. But stage 1, patient has decreased awareness of pain, sometimes with amnesia. Consciousness may be impaired, but is not lost. So this is where you might be in the pre-op area. They're getting ready to take you back to the OR, and they inject it into your IV, and you're starting to lose consciousness. You feel incredibly sleepy. Nothing really hurts. You don't really remember that, the whole trek from pre-op into the OR, because somewhere along the line you slip into the surgical anesthesia, which is stage 3. You kind of skip stage 2 and you go right into stage 3. Stage 2, we'll talk about when you're coming back out of anesthesia, because that's most often when it occurs. So they usually give you enough, if they're going to put you under general, to move you from stage 1 to stage 3 and then stage 4. Stage 4 typically doesn't happen until you're in the OR, on the OR table, and they're getting ready to get you started. That's at the point that they want you completely out of everything. And they don't want you to go too far into stage 4, okay? Some procedures, they need to take you into stage 4, because they are going to do a significant enough procedure that they need you, how do I say it? Most surgical procedures that are under general anesthesia go to stage 3 and they stay there. Occasionally, they need to take you to stage 4, and that's a very tight line there. A stage 4 might be like a heart transplant or a lung transplant, where they're trying to slow things down and they bring in a machine that does artificial breathing and artificial keeping your blood pumping through your heart, or through your body if they're doing that. So stage 4 is very rare. It is typically when they're doing something significant like a heart lung transplant, or they're doing heart bypass surgery, things like that, where they're going to use additional machines to do your breathing and or cardiovascular pumping type activities. Most surgeries are going to be stage 3, and they want to take you from stage 1 to stage 3 right away because they don't want you in the middle. Look at what happens in stage 2. Stage 2 is delirious, excited, enhanced reflexes, which can mean flailing out, and respiration's irregular, which can also cause anxiety, panic, and hitting out or moving or what have you. And that's where you can also have nausea, vomiting, and incontinence. So you can see that ideally you want to go from stage 1 to 3 and from 3 to 1. But because every person is different and every individual has different health factors, different weight, different responses, different surgical procedures, different anesthesiologists, different surgeons, you name it. Every situation is a bit of a different twist. And sometimes, no matter how good it is, you can end up with some stage 2 type things. But for the most part, your anesthesiologist is trying to get you stage 1 to stage 3, stage 3 to stage 1. And so that's why. But this is why you can see, if you understand what the stages are, you can understand how someone could end up accidentally hitting stage 2 and having that nausea, vomiting side effect. This talks a little bit about conscious sedation, where you have IV agents with local anesthetics used. You may have heard about conscious sedation. It is not general anesthesia. It really it's not necessarily local and it's not necessarily regional, but conscious sedation is used more with regional anesthesia. So I'm not going to touch a whole lot on this. I'm also not going to get into the mechanisms of action and how these actually get down and work and what have you. So, what do you need to know? Inhaled drugs. Again, the brand names are in parentheses and the generic names are outside of those. So you need to know sevoflurane or Altane, desflurane, Suprane, isoflurane, Florane. IV drug names to know: etomidate or amidate, ketamine or Ketalar, propofol or Diprivan. Side effects of general anesthetics include decreased respiration, nausea and vomiting, hypothermia, which is reflected in chills, and anesthesia awareness. And we'll talk about anesthesia awareness in a minute. So, how do you know that someone's not progressing the way that they need to through the stages, either forwards or backwards? You see decreased respiration, nausea and vomiting, hypothermia, or chills. That's when you know you either need to take them further under or you need to bring them completely out. And depending on what's happening with the surgical procedure, that may be the case. When I had my first child, I had a C-section. And I remember at one point toward the end of the C-section, I developed hypothermia and chills. And I remember that they moved me from a spinal anesthetic into general and just took me right under. And that took care of the whole problem. Um, so that does sometimes happen. All right, anesthesia awareness. It estimates vary, but about 1 or 2 people in every 1,000 may end up being partially awake during general anesthesia and experience what is called unintended intraoperative awareness. Um, they usually don't experience pain when this happens, but they wake up, or they at least become partially awake enough to hear what is being said in the OR. Because of muscle relaxants that are given before surgery, they're usually unable to move or speak to let doctors know that they're awake or experiencing pain. And for some patients, this may cause long-term psychological problems similar to PTSD. The phenomenon is so rare that it's difficult to make clear connections. Some factors they think may be involved include an emergency type surgery, cesarean delivery, depression, uses of certain medications, heart or lung problems, if someone's been doing daily alcohol use, if the lower anesthesia doses that are necessary, for whatever reason, they use a lower anesthesia dose than necessary. For instance, a lot of drugs like that are calculated based on weight if they don't have an accurate weight, or if someone's metabolism works faster than somebody else's, they're metabolizing the drug out faster. Occasionally, it can be an anesthesiologist or nurse anesthetist error when they're not monitoring the patient or measuring the amount of anesthesia that's in the patient's system during the procedure, because they want to keep what should be happening is that they're monitoring it to make sure the patient has the same amount of anesthesia in their system throughout the procedure. So once they take a patient under and they get them to the appropriate level of unconsciousness and lack of pain, they should be maintaining them there. And if for some reason it doesn't get maintained and it doesn't get noticed, anesthesia awareness can happen. So quick quiz questions. What is the purpose of general anesthesia? What does it do to the body? True or false? General anesthesia causes absence of all sensations, including consciousness. True or false? Drug mechanisms for general anesthesia are well known. Name at least 5 surgeries you would expect to be performed under general anesthesia. What are 2 routes of administration for general anesthetics? Name at least 2 generic and 2 brand names for general anesthetics. List at least 3 side effects of general anesthesia. What is anesthesia awareness, and how often does it happen? All right, the last part of this that we're going to cover for this week is local anesthetics. And when I say local, that includes regional. Local anesthetics are used to induce the absence of sensation in a specific part of the body. Regional anesthetics is used to induce the absence of sensation in a region of the body. In both cases, local and regional, consciousness is maintained. That's the biggest difference with general anesthesia. General anesthesia, consciousness is not maintained. They want the patient to be completely unconscious. And general anesthesia means they're anesthetizing the whole body. Local and regional means they're only doing a specific part or region. So a local anesthetic could be that you're getting stitches in your hand. And so they'll use a local anesthetic like lidocaine to numb that part of your hand where you're getting the stitches. A regional anesthetic or regional block might be where they're trying to numb you from your waist down because they're doing a procedure on your thigh or on your calf of your leg, and they're just trying to numb that region. They don't want to put you all the way under. because maybe whatever they're doing can be done while you're still conscious. Another example might be an eye procedure that you might, they might use local anesthetic and do sort of a conscious sedation where you're somewhat conscious during the procedure, but you've lost sensation in that area or that region. So it may be used with or without sedation. So for instance, if you're getting stitches in your hand, they're not going to sedate you unless there's some type of extenuating circumstance. But if they're going to do a procedure, say on your hip or thigh, and they will likely sedate you even if they're just doing a regional block. Most block nerve conduction. Okay, so local and regional anesthetics, they block nerve conduction, starting with a loss of sympathetic nerve function, progressing to loss of pinprick sensation, then to loss of temperature sensation, and finally to loss of motor function. And this makes perfect sense. Obviously, if they want to block those nerves, and they want to get to the point where they can control it, they may not want you to lose temperature or motor function, but they want you to lose pinprick sensation. Or maybe they want you to lose pinprick and temperature, but they still want you to be able to move it when they tell you. So local and regional anesthetics are a lot more controlled or controllable because they're not shutting down the absence of sensation of the whole body. Local and regional anesthetics, their effect is reversible, and their use is almost always followed by complete recovery of nerve function with no evidence of structural damage, meaning that complications are rare and usually minor. Local and regional anesthetics, when you divide them up, they're divided up by ester or amide. And you're going to be looking for drug names that end in cane, C-A-I-N-E. So lidocaine, novocaine, that type of thing. And so here's an example. Group 1 is benzoic acid esters, and group 2 is amides. And you can see that they all end in cane, C-A-I-N-E. If you see cane, you can pretty much guess these are going to be local or regional anesthetics. Routes of administration. These include basically everything you can think of. Local anesthetics can be administered topically, transdermally, through local infiltration, or subcutaneously, IV, IM, nerve block, spinal, which is also known as intrathecal, epidural, caudal, oral, catheter delivered, intranasal, inhalation, sublingual, rectal suppository. So, you have general anesthetics, which are all either inhaled or IV injections. Local anesthetics are pretty much anything. Regionals are usually injections, but your local anesthetics, they have such a wide variety of ways that they can be administered. Some types of regional anesthesia, you may hear of nerve blocks. They have peripheral nerve blocks. They have what's called a Beer block or an intravenous regional anesthesia, central nerve blockade. Then there are topical anesthesia, tumescence anesthesia, systemic local anesthetics, and things like that. So there are all sorts of anesthesias. And this was just here for informational purposes only. And this is a visual of how a patient would be getting a spinal anesthesia for a spinal block. And then these are a list of drugs that are used for spinal anesthesia. And I'm not going to make you know that they are spinal anesthesia. All I'm going to say is, do you notice that they all end in cane? And that obviously they must be local or regional because they do. What about adverse reactions to local anesthetics? There are some. There have been toxic responses causing central nervous system effects, cardiovascular effects. There can be drug-unrelated reactions that can cause psychomotor or responses or sympathetic stimulation or operative trauma. There can be idiosyncratic responses. Some of those have been documented. And then there can be allergic reactions. But some of those are related to some type of hypersensitivity or just some type of reaction. You can have contact dermatitis where you have swelling at the site. You can have hives as your body reacts to that. Some people react to the additives or preservatives that are in the local anesthetic, and that's what causes the issue. All right, last set of quick quiz questions. What is the purpose of local or regional anesthesia? What does local or regional anesthesia do to the body? True or false? Local or regional anesthesia causes the absence of all sensations, including consciousness. True or false? Drug mechanisms for local or regional anesthetics typically fall under ester or amide in terms of function or structure. Name at least 5 procedures you think are performed under local or regional anesthesia. What are at least 4 routes of administration for local or regional anesthetics? And then name at least 3 generic names for local or regional anesthetics. And again, just make sure that you can pick them out if you see them. You don't necessarily have to know them all and be able to spell them all, but can you pick them out? Again, all of your quiz questions this week are coming from these quick quiz questions. So if you know the answers, you will be well set for your quiz. Take care, have a great week, and we'll be back next week. We'll be moving on and actually tackling antimicrobials. So we'll get into some antibiotics. Take care.